Echo for this week. I think we all know by now that GECO is hosted on a weekly basis. It's hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. And this is going to be the last session for the year. It's a lower GI endoscopy session. We decided to focus today's session basically on the utility of rectal EUS. And I think EUS has been expanding quite rapidly in this last few years. Many more people performing EUS, and we've all probably come across an EUS talk in the upper GI and being increasingly familiar with the utility of EUS in the upper GI. But I think as the role of EUS expands, it's going to expand more into the lower GI as well. And this is still a bit of a black box for a lot of us. A lot of people aren't doing it. And so this really just serves as an introductory talk to just take us through the utility of EUS. Dr. Mokgoko has some experience from Charlotte with rectal EUS. I know we've trained a few abscesses, and I think she actually just trained a pelvic abscess just last week or the week before. So Dr. Mokgoko is going to take us, she's quite experienced with upper GI EUS and with lower GI EUS. So she's going to take us through the utility of EUS in the lower GI, essentially. Thanks, Dr. Mokgoko. Just by the way, the chat is open for any questions, so please feel free to post your questions during the talk, and we'll try and address your questions at the end of the talk.
Okay. Are you able to see my slides?
Yes, we are.
Okay. Good afternoon, everybody. Thank you very much for that generous introduction, Dr. Lala. Welcome everybody to this last session of the year. It's been quite a dynamic year this year, and a lot of new programs have been introduced onto the GECO platform, and we've all sort of benefited from all the talks that have happened this year. And I think it's a very exciting time to be a gastroenterologist and certainly to be a fellow. So I'm hoping I'll be able to share some light on, as Vikash said, a rather difficult and not as well known area of endoscopic ultrasonography, which is rectal EUS. And hopefully take you through a cook's tour of what this particular investigation and its interventions can entail. So that's a little bit of what our plan for today is going to be, an outline of our talk. I'm going to go a little bit over some background on endoscopic ultrasound as a modality, as a diagnostic and therapeutic tool. We'll go through the anatomy of the rectum and what you're actually looking at on endoscopic ultrasound, so it looks a little less shades of gray and black and white and in between. Then I want to talk to you about an introduction to performing rectal EUS, what to actually physically do if you're at the bedside and you want to start doing and performing rectal EUS. And then we'll talk about some indications in clinical practice and what the sort of future looks like for therapeutic rectal EUS. And of course, right now, the topical therapeutic indication right now is the drainage of abdominal and pelvic collections through transrectal and transcolonic methods. And then we'll talk about some new things that are happening in that space as well. Now, I'm aware that Dr. Chris Zaidi earlier on in this year also spoke about EUS as a modality, but I just do want to take you through some general concepts, especially for I know we have varied members of the team here that attend this platform, and just for people who are not necessarily familiar with endoscopic ultrasound. So what EUS is essentially is a combination where radiologists and gastroenterologists come together in a scope. It's an endoscope with an ultrasound transducer. It's technology that's been available to us since the 1980s, when somebody figured out if we do ultrasound from the inside out, we're likely to get better quality pictures. The problem with the endoscopic view on an EUS scope is that it's at a side viewing orientation, which means that you don't necessarily see the lumen as well as you are used to as an endoscopist, focusing on the luminal view. It's a thing to learn to really focus more on the endoscopic view. So if you look at a transducer, it sends out, we've got a radial echo endoscope and we've got linear echo endoscopes as well, where the transducer is at the very tip, and these would be your endoscopic optics on the side that really focus more on the wall of the GI tract. The transducer sends through sound waves, electric waves that are put through the machines are transformed into sound waves through the actual transducer. and that's sent out into the tissue. And depending on the quality of the tissue, it interacts with those sound waves in different ways. So fluid, for example, will transmit ultrasound. Tissue, depending on the different, sort of depth of the tissue, it'll absorb ultrasound and also allow the sound wave through. Bone will not allow the sound wave through at all. And in fact, you get no image when you're imaging bone. And air will actually reflect sound waves back to the transducer. This information comes back to the transducer, and it is then reconstituted to create a 2D image of the tissue structure. And so once the ultrasound waves have gone through into a tissue and those ultrasounds have come back to the transducer, you get an ultrasonographic image of what you're looking at through the wall of the GI tract or just outside of the wall. Of course, now we're able to get really high resolution real-time imaging of the GI wall, and we've got higher frequency ultrasonography and transducers, which is called the mini probe, that actually are able to give you much higher depth and much higher resolution of the GI wall. We also have newer add-on technologies. We can evaluate vascular structures like Doppler signal. That's been available to us for a while. But there's also newer and emerging things like elastography, which essentially looks at how compliant the tissue is and looks at how hard or soft a mass or an organ might be. And now we have the ability to also instill contrast media and evaluate vascularity of certain tissues, which can tell you about malignant or inflammatory conditions. Okay, so let's talk about the different kind of echo endoscopes. So we've got two main types. We've got the radial EUS and the curvy linear EUS. We call that just the linear EUS. And then there's the mini probe that I'll get into a little bit later. Both of them have the capacity of putting a water balloon and improving your image quality through the ultrasound. And of course, water transmits ultrasound a little bit better. The radial EUS sends out, or the transducer sends out ultrasound waves at perpendicular to the actual tissue or the GI wall, which means essentially you're able to get a 360 view of what you're looking at in the GI wall, which looks a bit something like that, like a coronal view on a CT scan. The anatomy is a lot more sort of familiar to us from looking at scans, as opposed to a linear EUS where the transducer actually sends out sound waves in an oblique fashion. And so it's parallel to the tissue that you're looking at. So it's a little bit sort of different in terms of anatomy and looking at, particularly in the upper GI tract. It's a bit of a learning curve if you've learned on the radial, turning over to the linear EUS. But what the linear EUS introduced to us is the presence of a working channel that previously wasn't there on the radial EUS. And the working channel means you can put all sorts of equipment down that channel and add on both diagnostic as well as therapeutic value to the linear EUS, which means we can sample tissue, we can intervene, and we can also do a whole lot of endoscopic interventions. As I mentioned, we attach a balloon to the distal end of the transducer to transmit sound waves or ultrasound waves a bit better and improve the quality of the images that you get. With both the linear and radial EUS, you can have a depth of 3 to 8 millimeters, which means you can see quite low down away from the GI tract to evaluate extraluminal structures. Okay, so as I mentioned, you're looking at the intestinal wall and looking at extraluminal structures. So when you're looking at the wall, you're going to get an ultrasound image, something like that, okay? That looks a bit like this. And you're not going to get the normal histology that you usually would see, or you're not going to see what you usually would see with a luminal view. So you're going to get these 5 echo layers, and these are consistent throughout the GI tract, whether you're in the duodenum, the esophagus, the stomach, the rectum, this is all the same, where you have the first layer being hyperechoic, and we talk about hyperechoic as being bright as a reference, yeah? So it looks whiter on ultrasound, and hypoechoic or dark bands, and those tend to be the bands that have a lot of muscle in them. So the second layer is going to have a lot of muscle in it, which is the muscularis mucosae, and then the muscularis propria, which is the 4th layer here. Like I said, we can then attach Doppler signal, elastography, and contrast media that tells us more about the quality of or the properties rather of the lesion that you're looking at. Is it vascular? Is it is it cystic? Is it a solid lesion? Does it have calcifications? Is it harder or softer? Things that help you delineate or try to predict with better sensitivity what the most likely histology of what you're looking at is going to be. Are you able to see my pointer, by the way, Sandy?
No, we can't see your pointer.
You can't see my pointer.
Okay, now I can see it. Yes, it's there.
You see it now. Okay. All right, fine. Then enter the EUS mini probe that we don't have available here. But what an EUS mini probe is essentially a very high frequency EUS probe that can be passed down the working channel of an average therapeutic endoscope. What that means, endoscope all the way to the right colon, for example, which you can't do with side viewing scopes. It also means that you can get really high frequency GI wall detail, or even extraluminal, but more for GI wall detail of the echo layers, which means you turn what was the 5 layers histologically into 5 layers on EUS with an average EUS scope, now becomes subdivided into 9 layers with the mini probe, because your frequency is all the way up to 30 hertz. Your average EUS scope is somewhere around 12 to 15. So you get an image that's like that with average radial or linear EUS. Okay, in this instance, it's radial, where you're seeing from the mucosa down to the serosa. That image becomes transmitted into that, where you can see subdivisions within the tissue. The mucosa is divided, for example, into two different layers. The muscularis propria into 3 or 4 layers, depending on whether you can see the inner circular, the fibrous band in between, and the outer circular layer, which you can tell for tissue evaluation of infiltration and tissue TNM classification of lesions of the GI tract, means you can be quite detailed in terms of figuring out the tissue of origin and the characteristic of the lesions that you're looking at. We now know that we can use the mini probe, for example, in the standard ERCP scope, and evaluate biliary pathology, being able to know if a cholangiocarcinoma is infiltrative or not, or evaluate even indeterminate strictures in patients with PSC. And again, like I said, where the right side of the colon has been relatively inaccessible up until now to EUS because of the side viewing endoscopic view of an echo endoscope, having a mini probe means you can use a standard colonoscope and have a look at the right side of the colon using the mini probe put through the working channel. So what that means with the linear EUS and the availability of this very small working channel and being able to put things like a needle in there or a lumen opposing metal stent means it's opened up endoscopic ultrasound, which we're all aware of now, into this big field of interventional echo endoscopy. Its role in HPV disease, for example, in the management of both benign and malignant pathology, allowing us to do an EUS guided liver biopsy, for example, to measure portal pressures, to even place a stent and do a portosystemic shunt, to evaluate, endoscopic evaluation of varices and being able to treat them, put a needle down there and put a coil and inject glue under direct visualization, as opposed to using a normal G-scope where you are essentially targeting the lesion and hoping you're injecting in the right plane. Obviously, the advent of lumen opposing metal stents and being able to drain peripancreatic collections. Also, we then realized we can actually start opening that field of endoscopy into other indications, draining lumens we couldn't get into before. So endoscopic ultrasound guided bile duct drainages and proximal drainages with hepatogastrostomies, or even gastroenterostomies for patients with malignant gastric outlet obstruction. So the use in upper GI in terms of interventional endoscopy, echo endoscopy that is, has been expanding and it's well established, right? The issue is, what is its role in the lower GI tract? It's definitely less sort of known about. It's less established. There's less data out there about how to use EUS in the lower GI tract. As I mentioned, EUS is typically limited to the anal canal and the rectum. We can't go proximally into the colon with a side viewing scope because you lose the luminal view because it's a side viewing instrument. Although they do say, and it has been described, international experts have said, you can actually introduce a side viewing echo endoscope under water immersion and maintaining the echo endoscope in the lumen of the colon under EUS view, and by doing so, safely navigate a EUS scope through the colon. But ordinarily, the only way we were able to, up to now at least, evaluate the colon using EUS was putting in a colonoscopy and a mini probe, at least into the right side of the colon. Until we came up with the forward viewing echo endoscope, which has been introduced since 2010. Lots of prototypes have been made, but now there's an accepted, available forward viewing echo endoscope. What does that mean? That means that you have an echo endoscope that has the benefit of having a linear transducer, so it's like a linear EUS. However, the optics of the scope itself is actually forward viewing. So you have a forward viewing endoscope, which is reminiscent of your normal view of what you get with a therapeutic or a diagnostic endoscope, gastroscopy or colonoscopy, but you've added an EUS to the end of it, an EUS transducer at the end of it, to allow you to do forward viewing as well as echo views in the same plane. The problem is you obviously have to accommodate the side viewing endoscope component, which means you've lost some of your transducer. Where this is a normal linear echo endoscope, you're able to get a 180-degree view from your transducer. With the forward viewing echo endoscope, you're only able to get 90 degrees because of that surface area of the transducer. And you're able to get a little bit bigger endoscopic view because of the forward viewing orientation of the optics. So this means you can advance an echo endoscope under direct vision into the proximal colon. You can pass this scope into the right colon, be able to see an endoscopic view that you are used to as a practicing endoscopist, but also at the same time be able to have an EUS view of the wall and extraluminal structures. You also have a working channel on the forward viewing echo endoscope. That's exactly the same as what you would have on a linear echo endoscope, which means you can put down needles, you can put down, introduce guide wires, and even cautery-assisted lumen-opposing metal stent. The ultrasound transducer as well, meaning the quality and the frequency of the ultrasound transducer is exactly the same as the typical linear EUS, which means you haven't lost quality and crispness of the image. You've simply just gained a forward viewing endoscope. The ultrasound is just narrower, so the field is narrower of your ultrasound, but the quality is the same. And unfortunately, it lacks an elevator to tip down and forward, which might impact interventions and, when you're targeting a lesion in a difficult position. What this forward viewing echo endoscope has done is it's allowing us to access areas of the GI tract where we wanted to get into with a normal linear side viewing echo endoscope, but it's been difficult. So the right colon or proximal colon, paracolic areas, and being able to see anything outside of the colonic wall. And then more importantly, liver-hilar lesions, being able to evaluate them and even sample perihilar lesions or perihilar masses. This echo endoscope has been in use in clinical use and has also been introduced now into interventions where you can drain pseudocyst drainages and even place lumen-opposing metal stents through a forward viewing echo endoscope. So it's literally revolutionized echo endoscopy, particularly in the lower GI tract. It obviously has its uses in the upper GI tract, but more importantly in the lower GI tract, and being able to access the colon using EUS. So let's talk about rectal EUS, and I've excited you about what it is and what we can do with it. How do you actually get started, right? So let's talk bowel prep. You don't want to have any air or stool or, anything that's going to interfere with your interface, your transducer and your ultrasounds getting in and out of tissue. So you want to avoid air and stool. So all of the guidelines, both ASG and ESGE, say that you don't necessarily need to have a full colon prep schedule. So the split 2 liters of colon prep, because you're only, up until now, at least before we had the forward viewing echo endoscope, you're only introducing the echo endoscope to the rectosigmoid junction. You're not going more proximal than that. You give 2 doses, which is what we practice here, about 2 hours before the procedure. They're usually enough because you're only looking at that distal 20 to 30 centimeters of the left colon. If you are, however, looking to have really crisp views of the wall of the rectum, for example, if you're trying to figure out if your rectal lesion is a T1 or T2, is the invasion of the muscularis, you really do need for there to be no interface at all, no air, no stool, no fluid. And so you really then should consider doing a split dose bowel prep. Definitely, if you're going to do proximal colonic evaluation, you need full bowel prep. And if you're going to perform any interventional EUS, it is suggested that you have full bowel prep to optimize the chances of treatment success or technical success. It was also preferable to have a distended urinary bladder. That goes without saying. It's a very reassuring anatomical landmark to find. Sometimes it's the only one that you recognize with confidence. So having a full distended urinary bladder is important for starting your anorectal EUS. And again, it's fluid. It will happily transmit ultrasound, so it doesn't interfere with your procedure at all. You don't necessarily need sedation before an anorectal EUS. Again, you go into the rectosigmoid junction, but I would say if you're learning how to do rectal EUS appropriately for the comfort of your patient, a little bit of conscious sedation and some analgesia would do the patient well. There's no recommendation currently for antibiotic prophylaxis, except if you're going to be sampling or draining a cystic lesion or a perirectal collection. It's suggested to use a fluoroquinolone because of the rectal commensals and colonic commensals. Position, the general left lateral decubitus position in the knee chest position of colonoscopy. That's how you start. There's a little bit of technical issues in terms of placing your monitor and the stack on the same side so you can access it and perform your EUS comfortably. It is suggested that if you're looking at the lower rectum and the anal canal, that radial EUS, of course, is going to have higher sensitivities for looking at your anal sphincters, where linear EUS for the interventional component and tissue sampling is going to be better for looking at rectal, so higher up, more proximally, and the perirectal lesions, especially outside of the wall of the rectum, things like bladder and prostate. It also allows you, of course, has the better added benefit of allowing you to do EUS guided biopsy, or if you need to drainage, which I'll talk about a little later in my talk. Like any good endoscopist, you should do a PR prior to inserting your endoscope. You want to see if there's anything in that anal canal or in that distal rectum that you need to be aware of, any mass lesions, etc. It's suggested, if you have never done an endoscopy on this patient for obvious reasons, that you should start off with doing a sigmoidoscopy to identify any lesions if they are, and more importantly, to exclude luminal obstruction. Remember, this is the area where we're still using side viewing echo endoscopes, and so your endoscopic view is really limited. You don't want to cause a perforation, which can very easily happen in the proximal rectum. If, however, you need to perform a full colonoscopy because of the duration of the procedure and the fact that you're going to be introducing air, it does reduce the sensitivity of your EUS because of air artifacts. So if you need to do a full colonoscopy, it's suggested that you do the sigmoidoscopy, try to remove as much air as possible, use water immersion thereafter. Perform your EUS during that same session, and then complete your colonoscopy thereafter. Okay, so what do you actually do? So ideally, you should use water-filled balloons or water that has no air in it if you're going to be using a foot pump. So use a sort of airtight container and use a foot pump, and ideally not introduce any air into the rectum. The amount of water that you use, if you've only used an enema and you haven't had full bowel prep, you should try not to instill more than 200 mils of water into the rectum to avoid a waterfall of proximal stool that will obviously affect the sensitivity of your procedure and might even lead to you having to abandon it because of technical difficulty. So how do you start? Firstly, to just remember that you're going to be moving differently with EUS than you do with your normal scope. Where with a colonoscopy, you're requiring on the forces of torquing. Here, you're really turning the scope. It means turning the entire scope on its axis, either clockwise or anti-clockwise, and it means introducing in and out, so advancing towards the proximal proximal rectum, and then distally towards the anus. Will be in and out insertion of the tube. And then you also have an elevator, which will let you, angle towards the luminal wall and away from the luminal wall. You also have big wheel and small wheel, which is right and left turn. So you start by introducing your scope in the 0 position, which will allow you to see the anterior wall. You place your scope at 20 centimeters from the anal verge. So you introduce your scope, trying to maintain the endoscopic view if you can, to avoid causing any mucosal injury, to 20 centimeters from the anal verge. That should put you at about the rectosigmoid junction at the very top. If you consider, a rectal distance of about 12 to 15 centimeters. So identifying the vascular structures is the first thing. Once you get to 20 centimeters, try to remember your movements, move your scope clockwise, counterclockwise, and try and identify vessels if you can. If you're able to follow the common iliac artery down to its bifurcation into the internal and external iliac arteries, that's where you start looking for nodes. In this area here, at the top or the top third of the rectum. The rectum is evaluated in thirds, top third, middle third, and the lower third. So in this area, you're going to be looking for any lymphadenopathy. You're also moving your scope. If it's a linear scope, remember, radial scope will give you 360 view. If it's a linear scope, you're going to have to move your scope clockwise and counterclockwise to try and make sure that you're covering all the walls of the rectum and seeing both anteriorly, posteriorly, left and right of the rectum. Evaluate all the 5 layers circumferentially, again, with the linear scope, as we mentioned. Look for any subepithelial lesions, any mass lesions. If you do have a lesion already that you know about from doing your sigmoidoscopy, you want to get proximal to it and come down so that you can evaluate the borders and the entire lesion and not miss any part of the lesion that might be invading into deeper structures or deeper parts of the wall. All right. As I've mentioned, and then you want to inspect the rectal wall and periluminal structures while you slowly withdraw. So you're going to be clockwise and counterclockwise turn, as well as moving the scope slowly distally until you reach the middle rectum or the middle area that we're going to be scanning now. So as I've mentioned, you're looking at your 5 layers. You're looking at different parts of the rectum from the proximal rectum down to the middle and then the lower rectum. So when you start withdrawing slowly from that 20 centimeters, you want to try to see if you can find the bladder. Like I said, the urinary bladder is a nice big hypoechoic structure with 3 different layers in terms of its wall. It's easy to find in both males and females. And it's a nice place to start as you start scanning the rectum via EUS. Again, clockwise and counterclockwise rotation to start bringing some of these structures into view. In the male, between the bladder and the rectum, you're going to find the prostate, and just above that, you find a hypoechoic sort of banana or U-shaped structure that's called that is the seminal vesicle. You're able to evaluate the rectal wall, right, and you change depth on your scope to be able to look at different frequencies. So if you want to see deeper away from your transducer, you're going to have to go deeper, but you lose sort of crispness of the view. So the quality of your picture as you go deeper into the tissues becomes less. And if you want to evaluate the wall, you decrease your depth and you zoom in on this area to be able to evaluate for subepithelial or intramural lesions of the rectum. In the female, of course, the anatomy changes. There's no seminal vesicle or prostate. There's going to be a vagina sitting there, and then more proximally into the uterus. And you might find it might be filled with air, the vagina, sorry, and then and the uterus sometimes may be filled with fluid. So when you move towards the mid-lower rectum, this is where you want to start identifying the sphincters. So you're coming down from, and I'm going to go just up there from your wall, because you're going to use the wall as of the rectum as your reference point. The extraluminal structures are really extra to look at, but what you're more interested in with rectal EUS is the wall of the rectum itself. So you're moving your scope in this direction and keeping an eye on your 5 echo layers. So when you get to 4 centimeters from the anal verge, so not quite at the lower rectum or the anus, somewhere in the middle, following the wall down, you're going to see that the inner circular muscle layer of the muscularis propria starts to expand and gets a bit bigger, and then becomes or continues as the internal anal sphincter. Okay, this is a good area here to use water or to use a water balloon to be able to see this detail in your actual echo endoscope. It becomes quite difficult if there isn't a water interface. Right. As I've mentioned, the internal anal sphincter is a continuation of the inner circular layer of muscle as it goes down into the anal canal, and it's a hypoechoic. Remember, it's muscle, so it's going to be hypoechoic going down, and you're able to see the anatomy of, or the relation of, the internal anal sphincter as opposed to the external anal sphincter, which is a little less easily defined and a little more difficult to find, because remember, this is coming from your pubic muscle, not necessarily the wall of the rectum. And so following down the wall of the rectum from mid-rectum to the anal canal is what's going to happily get you into the area where you can identify the internal anal sphincter. And then you see an area here that's hyperechoic. My apologies. An area here that's hyperechoic, which is the intersphincteric area, basically just connective tissue and a little bit of pararectal fat. And then you see the external anal sphincter in that area. Okay, you may be able to identify the puborectalis sling muscle that goes all the way around the anal canal and then ends up at the external anal sphincter as well. The internal anal sphincter shouldn't be bigger than about 2 to 4 millimeters. The external anal sphincter is a bit more indistinct, and it's not easy to actually measure its depth necessarily. These are all perfect pictures. In the average patient, it's not necessarily this easy to find. Okay, so when you're at the anal canal, so that means you're moving distally and into the anus, which is essentially where your scope is about to fall out of the bum. You're going to evaluate the anorectal junction and be able to see the circular muscle of the muscularis propria that's continuing as the internal sphincter. So we're going distally here with the anus at the very end, and this is what it looks like in the textbook, and more likely what it looks like in the patient. So following the internal sphincter is going to be the most reliable sort of echoendoscopic structure that you can see. The intersphincteric area, as well as the external anal sphincter. This is where you want to look for any perianal abscesses and fistulae. Remember that the internal anal sphincter stops short of the anus, and only the external anal sphincter continues beyond that point towards the anus. So there's an area where this muscle layer will abruptly end. Okay. Right. So now that we know a little bit more about anatomy, and we have to practice it a little bit more, even I practice it quite a lot. Vikash and I are always looking at gray areas in the rectal EUS and trying to figure out where we are. But again, if you follow the 5 echo layers and sort of follow the muscularis area reliably, that's what's going to get you all those anatomical structures. So when we talk about rectal EUS, there are a couple of indications, a couple of patients where you're going to have to go in with the rectal EUS and see and be able to advance the diagnostic or therapeutic management of those patients. These are going to be patients where you're staging rectal cancers and trying to, decide about local resection, or if it's surgical intervention, the type of surgical intervention that the patient needs. Evaluation of rectal subepithelial lesions. They're not uncommon in the rectum. Subepithelial lesions, a small bulge, and you're trying to figure out, is it a neuroendocrine tumor, a lipoma, or something a little bit more sinister. Of course, assessment of anal sphincters in the anal canal, evaluation for patients who have fecal incontinence, abscesses and fistula with inflammatory bowel disease or without. And also being able to monitor therapeutics for perianal abscesses and fistulae. You are able to also look and evaluate for pelvic lesions, things like prostate cancer, and look for pararectal mass lesions and be able to sample those as well. And of course, what we're here to talk about is EUS guided drainage of pelvic collections. Right. So when you're looking at rectal EUS in its utility for staging of rectal carcinoma, it has really fallen a little bit out of favor in terms of when you compare it to pelvic MRI, because of the advances in pelvic MRI and being able to actually see the pelvis as a whole and evaluate the mesorectum and decide about margins and the need for adjuvant therapy. So in rectal carcinoma, it's one of the ones where, you know, tumor invasion and wall invasion is important in staging the patient and evaluating prognosis, of course, and deciding about appropriate treatment. EUS is best used for evaluating for T1 and T2 tumors. So invasion of the submucosa versus invasion of the muscularis. That seems to make a big difference in terms of deciding if your patient can go for something that is an unblocked resection, like an endoscopic submucosal dissection, or even an intermuscular resection, or a patient who really needs surgery. So that's where your role of EUS is going to be compared to MRI. MRI is going to be better at evaluating any vascular invasion, any invasion of pararectal structures and nearby structures like bladder and uterus. And also telling you about the mesorectum, which is very important in terms of deciding if your patient can have surgical resection without neoadjuvant therapy or chemoradiation, or if they would need chemoradiation and the type of surgery that they would need. So essentially in rectal EUS, unless you think your patient is going to qualify for getting a localized resection like an ESD or an EID, MRI is going to be your local regional imaging of choice. It also allows you to evaluate a greater area and see a bigger space in terms of surgical resection. There is a role for the evaluation of premalignant polyps, and I know Vikash is going to get excited now in terms of where you may be doubtful of your endoscopic evaluation. You know, we're all doing high quality endoscopic evaluation and learning about vascular patterns and demarcated areas. But where you're not sure, before you go in for a local regional procedure or endoscopic resection, you can evaluate using EUS for invasive carcinoma or a nodule in a really large polyp, where you may be considering that there might be an area where you might have submucosal invasion. And then rectal subepithelial regions or colonic subepithelial lesions, it's very common to come across a small little lesion just as you retroflex or is about to retroflex. Usually they're asymptomatic and incidental findings. They're usually not something that the patient comes in for. And you may be unsure looking at the endoscopic view whether this is something that's in the lumen or it's interluminal, or if there's an extrinsic compression. And that's where rectal EUS is of great utility, being able to figure out if this lesion is coming from one of the echo layers, the rectal wall, or if it's coming from outside from a pararectal a mass lesion like a vaginal malignancy, for example. Of course, in the proximal colon, as I've mentioned, you would either have to rely on a mini probe where you insert the mini probe using a colonoscope, or if you are lucky enough to have access to a forward viewing EUS to be able to also do an FNA or an FNB of the lesion that you find to get a histological diagnosis, because at the end of it, that's what helps you decide about what the way forward for your patient might be. As mentioned, you evaluate the layer of origin and the echo structure and the properties of this lesion. It guides a method of resection if you do EUS on a rectal lesion, and there's some lesions in the rectum that have very particular endoscopic features. Lipomas, for example, are very intensely hyperechoic because they're full of fat. Neuroendocrine tumors and just might be a little bit more difficult, but you can evaluate what the lesion most likely is with EUS. Also, the evaluation of rectal varices and even the treatment of rectal varices can be helpful when you have rectal EUS available. What about perianal fistulae? Okay, so rectal EUS performs better than CT and a fistulogram, but and it has a similar sensitivity to MRI, but MRI does outshine it in terms of being able to evaluate for luminal inflammation, or of course involvement of pararectal structures. But the benefit of EUS is it's available at the bedside, right? So as you do your colonoscopy and your retroflex and you look at the anal canal and the rectum and you think you find an internal opening, or you think you find a anal abscess on PR, this is where you can switch over easily to an endoscopic ultrasound and be able to evaluate that lesion a bit better and come to a diagnosis. Like I mentioned, the MRI has a benefit of evaluating fistulae in relation to pelvic organs like rectovaginal fistulae, and being able to evaluate luminal disease within the rectum, and of course more proximally in terms of the rest of your colon and even small bowel. In terms of perianal fistula, they tend to appear hypoechoic because they're full of fluid or pus, and they might have hyperechoic internal echoes because of that liquid content as well. And the presence of gas, bubbles, or echogenic material that is reflecting the echo, you're not able to see through it, so it should suggest that there's an abscess involved there if you're seeing air in your in relation to this perianal fistula or a collection. EUS drainage of pelvic abscesses is now a possibility. I'm going to talk about that now. You can do that even in patients with Crohn's disease with good technical and clinical success with both pigtails or even lumen-imposing metal stent, like a hot axius. You're able to evaluate with the forward viewing EUS. You'll be able to look at things like wall thickness more proximally in the colon, and evaluate for pericolonic lymphadenopathy and other collections that need to be drained as well. There's also a use of endoscopic ultrasound in evaluating things like inflammatory strictures associated with active Crohn's disease versus fibrotic strictures by using contrast. For example, if you put contrast next to a stricture and on EUS it lights up, that suggests that there's active inflammation as opposed to something that's more fibrotic. And in terms of evaluating UC versus CD, there are some people looking at whether you can use endoscopic ultrasound and evaluate wall thickness and which area of the wall is actually thickened in helping you differentiate patients with inflammatory bowel disease who might be a little bit indeterminate and have features of both. With ulcerative colitis, the mucosa is thickened, the submucosa is normal, and with CD, you have thickness of the submucosa and the muscularis as well. There are other lesions that you can evaluate with rectal EUS, where you find a lesion in the rectum that might look a little bit elevated or have rolled edges, and you're worried about it being a malignant mass, but it's a young patient and the history doesn't fit, and you're worried about a solitary rectal ulcer. You can easily be able to evaluate if this is a benign or malignant lesion with endoscopic ultrasound. You might need ancillary investigations like an MRI and of course histology, but you'll be able to reassure the patient that this is most likely a benign lesion by looking at the submucosal layer and the muscle layer being a little bit enlarged without any mass lesion being associated with the ulcer. Evaluation of fecal incontinence, I've already alluded to in terms of evaluating the structure and the integrity of internal and external sphincter, or evaluating if there's any disruption in the anatomy of the sphincters as well. These are for patients that have had maybe sphincter trauma. You can see that there's a disruption in the sphincter, or patients who have had post-anorectal surgery and are complaining of fecal incontinence. So what about being able to actually perform interventions with rectal ultrasound? So its diagnostic value is well established, but what about intervention? So the biggest really field where we've been able to really use the rectal endoscopic ultrasound for interventions is being able to drain pararectal or paracolic abscesses, paracolic in the proximal or distal sigmoid, or higher up in the rectum, and pararectal really lower down. So abdominal pelvic collections can occur from a variety of etiologies, but most commonly post-surgical, post-perforation of a viscus, and diverticular abscesses. Of course, in the setting of IBD, they can be quite common as well. And the literature suggests, so the guidelines are, if it's more than 3 centimeters, regardless of symptoms, it really does require drainage because it's likely to fail medical therapy like antibiotics alone. So for the most part, if there's a paracolic or pararectal abscess, it requires a combination of antibiotics and some sort of image-guided drainage. And up until now, that image-guided drainage was only percutaneous pigtails availability. And if that wasn't amenable to an image-guided method or percutaneous method, then the patient would end up having surgery if you couldn't drain that pelvic collection. But now we can access pelvic collections through the rectum and in the sigmoid, and it's being done more readily and with greater confidence. It's a bit unnerving when you first start out, but you're able to actually get quite good positioning. So, and with pelvic collection, of course, the problem is you're going into an area with that's of high vascularity, lots of viscous involved, bowel and other pelvic organs. And the issue is that the percutaneous route may not be available, meaning you may not be able to access the collection itself through the percutaneous route. So EUS guided drainage allows you to have real-time access to the abscess cavity. It allows you to, sample and send off a pus sample first, or even sample any lymphadenopathy if you're worried about it being tuberculous, the pararectal abscess. You're able to very easily avoid intervening structures like vascular lesions, etc. You're able to get a better position from being in a shorter distance. Of course, it's an internalized fistula with transluminal stent placement. It's more comfortable for your patient. It's able to sit there longer. It causes usually not very much discomfort at all. And you can happily drain both using the transrectal and the transcolonic method. Of course, traditionally, and in terms of, the limitation right now is price in terms of using lumen opposing metal stents, but traditionally double pigtails were being placed. As you can see, there's a pelvic collection there. Being able to access the pelvic collection and scan for any, overlying viscera and, rectal lesions or even any vessels, and accessing that with a 19 gauge needle, placing in a guide wire and being able to then place a double pigtail stent over the guide wire and leave the drain in for however long the patient might need. And it will look something like that with pus draining from the cavity. Of course, now it's much easier and much shorter procedures to use a cautery-assisted lumen opposing stent like a hot axius, but you do also still have the option, if you have suboptimal drainage, to then place a double pigtail plastic stent through the actual stent itself, the metal stent, and gain better access into the cavity. But generally, a lumen opposing metal stent is enough. So how are we faring with this intervention, or how are they faring rather internationally? Locally, we might have to, do some case reports and case series to be able to tell you how we are doing. But internationally, the first sort of case series that was reported was in 2012 when they reported on a 7. It was a single center retrospective report on 38 patients that they did an EUS guided drainage of. And they sort of started off doing lumen opposing metal stent, double pigtail stents. I apologize, and then they sort of evolved into lumen opposing metal stents. So they started off by using deployment of double pigtail stents first. In terms of treatment success, right? They defined treatment success in placing these stents by patients who had no abscess and no symptoms at the 2-week mark. If you look at the patients here, and I'm sorry that might be a very small image, but I wanted to just bring your attention to some of the etiologies. If you look at the etiologies, the patients who had transrectal drainages were patients who usually are post-surgical leak of an anastomosis with a pelvic collection. Diverticulitis was not uncommon in these 38 patients. Not very many patients with IBD, and some patients with perforated viscous, especially appendix, which is a not uncommon indication for a pelvic collection. If you look at the size of these are not very small abscesses at all, about 6 to 7 centimeters, the largest of which were about 8 centimeters. So these are big collections that certainly will not respond to medical therapy and need to be drained in some way. And the commonest reason why they were consulted to try an endoscopic ultrasound or EUS guided drainage for these patients were that these abscesses were essentially not accessible. So these patients would have been drained via surgery if they weren't offered an endoscopic option to drainage. So if you look at the number of patients that they did, 11 of them were transcolonic, so proximal sort of sigmoid colon, and then 27 of them, by far the greatest number was transrectal. Technical success, and they define that as being able to place the stents successfully within one procedure. 100%, all 38 patients that were able to place a stent. The problem was whether or not that stent worked. So some patients required repeat EUS drainage or failed drainage, or didn't resolve the abscess, which means they had to go back with EUS. And some patients ended up having to go to surgical intervention. But you can see in the transrectal patients, 96% of them were successfully treated with endoscopic drainage. So 98% of those 27 patients avoided surgery. And some of these patients were relatively sick patients as well. The transcolonic route proved a little bit more challenging. 70% of patients were treated with EUS drainage, and a third of them ended up having to have surgery anyway for a variety of reasons. Blocked stents. One was a stent that actually got mal-deployed and went into the abscess. And what they found in this group is that diverticular abscesses drained via the transcolonic route tended to be the ones that required surgical intervention at the end. But you can see that you still can go back and do endoscopic ultrasound guided drainage should your patient maybe not be optimally draining, or you have a well-placed stent, but you still need better drainage, or there's thick sort of material within that abscess. You can still retry EUS guided drainage, even if you've done it once before. And then this came out earlier this year in the EUS journal, where they reported a greater number of patients. But you can see that even though it's a very high contact center, they still only had 60 patients over a period of almost 20 years that they reported on. And these are very skilled echo endoscopists. So how did they do it? How did they drain pelvic abscesses? They put in the double pigtail method, 19 gauge FNA needle initially, followed by a guide wire into the lumen of the abscess, and then they railroaded through a cystotome, burned a hole into the abscess, and then put in a second guide wire, and then deployed 2 7 French 4 centimeter pigtail stents after dilating the tract with an 8 millimeter CRE balloon. And as time went on, as we got closer to sort of the 2019s and the 2018s, they started putting in EUS guided cautery assisted lumen opposing metal stent. Essentially, that was hot Axius. Hot Spaxis wasn't available yet. And then they evaluated the patients at 36 hours post EUS drainage. They did a CT scan and evaluated if that was draining, if there was any mal-deployment of the stent, if the abscess was getting smaller, if there was any new abscess or free perforation. And then, the stents were only removed when there was complete or near complete resolution of the abscess on repeat imaging. And that was on average about at the 2 to 3 week mark. If you look at the types of EUS drainage and their technical success, I mean, these are people who are really experienced at doing endoscopic ultrasound and performing rectal EUS, I mean, as early as 2002. And they were able to place a stent in almost all the patients, in almost all 60 patients, in 97% of patients. They had technical success, so they didn't have a problem with deployment of the stents. In only 2 of the patients, they had a failure to deploy the stent. In only one of the patients did they have a distal deployment of the stent, and the patient had to convert to surgery. And one procedure was stopped, and the patient had to convert to surgery as well because of pain. They had very few patients that actually had any endoscopic ultrasound associated complications. Again, that was because of extraluminal stent deployment, where the surgeons then had to go in and fish out the stent and fix the perforation that had happened as well. So relatively safe, relatively successful procedures. We've been, like Vikash said, we've been performing them as well, a few of them. And we've had technical success. We've had one patient that we've lost to follow-up that hasn't come back, and we're hoping she ended up with the surgeon somewhere, but we haven't heard back from her. And we just placed a hot Spaxis into a pelvic collections just last week. They did have some patients who had persistence of abscesses, meaning they put the stent in and there's still a collection, or there's a new collection. And you can see that in those patients, they still managed to rescue the situation by doing another EUS guided drainage, and only 3 of them required intervention. Only 1 patient died from this series because of undrained abscess or sepsis, but this patient had other comorbidities as well. That was the reason why they wanted the EUS guided drainage in the first place. This patient was not a surgical candidate, and they had recurrence as well. But even when you've removed the stent and you had recurrence, you're still able to perform EUS guided drainage as well. Not necessarily, it doesn't mean that the patient is committed to a surgical intervention. So in terms of emerging indications, I've mentioned the forward viewing echo endoscope. That's sort of the most exciting, and that will open up the rest of the colon or the rest of the lower GI tract to EUS guided interventions, diagnostics, and active interventions. There's also been some case reports in terms of variceal coiling and glue embolization, borrowing from the upper GI tract and its management for patients with portal hypertension, being able to place a 19 gauge needle through under endoscopic ultrasound into a rectal varices and deploying a coil through the needle, and thereafter injecting some glue to gain hemostasis from patients who are not necessarily patients who can have surgical procedures. There are also some case reports that are reported on EUS guided anastomosis in the lower GI tract. There was an interesting case report I read about where the patient had a terminal ileal stricture, a Crohn's terminal ileal stricture, and the proximal terminal ileum that was super dilated was able to be accessed with a 19 gauge needle, and then they put a 20 millimeter hot axial stent from the terminal ileum under EUS guided ultrasound, of course, under EUS guidance, and they were able to place a hot axius into the terminal ileum and bypass the strictured component of the TI, and that patient did relatively well and didn't need any further intervention. Of course, you can do colocolostomies as well. That will probably be in the lower GI tract where you've got obstructing malignant lesions, and you're able to get a distance of colon close by on the other side of a obstructing malignant lesion and create a endoscopically essentially bypass the mass lesion and do a colocolostomy, anastomosis, anatomical anastomosis. Obviously for palliation in terms of EUS guided hypogastric plexus block, similar to what we do in the celiac plexus for patients with malignant pelvic disease, that is for palliation. Drug delivery in pelvic cancers, brachytherapy into the prostate using EUS, minimizing radiation for patients. And then, of course, in terms of rectal EUS, the diagnostic and therapeutic value is established now for various benign and neoplastic pathologies of both the rectum and the distal colon. And as we have the advent of the proximal forward-viewing EUS, we're able to expand those, hopefully, to the proximal colon and even more interventions that we're able to do with this very novel intervention. Thank you for listening.
Thank you, Didi. That was a very thorough overview, and I think what you said in the starting of the talk is absolutely right. It's a very exciting time to be a gastroenterologist, and with the advent of that forward-viewing EUS scope, our playground really is expanding, and the abdomen is going to become our oyster, and certainly be able to access more and more lesions and do avoid invasive procedures more and more. Really, that was an excellent overview. I can just ask one question. I don't see any questions in the chat. I just wanted to ask you, because this might be more pertinent to us now, where we are right now, rather than all of the future things coming up. But can you just maybe comment on the role of EUS versus MRI for the staging of rectal cancer?
Yeah, so as I mentioned, in terms of invasion through the wall of the rectum, unless you see very obvious nodal metastasis, patients who have very limited disease in the wall that are limited to T1 in terms of therapeutic intervention and resection can get unblocked resection and have no chemoradiation thereafter. Endoscopic resection, for example, even have limited surgery. And so it's important to figure out if this lesion is a T1 versus a T2. That's really where EUS plays a major role. If you're looking at local invasion through the wall and you're looking for whether this patient can have limited surgery or even endoscopic resection. In terms of its utility versus MRI done well with the appropriate sequencing and with the new advent of high quality signaling, it actually is better in terms of evaluating invasion into the mesorectum, as I mentioned, around that rectum, and figuring out what surgical procedures you can perform, and figuring out if there's any invasion into the mesorectum. As I mentioned, invasion into other pelvic organs, evaluating vascular invasion as well. All of that is better done with MRI. So where EUS used to be the primary modality of staging rectal cancers, it really has become a ancillary modality, or something that you use in combination with MRI. Of course, the other utility in looking for rectal cancers is looking for nodal metastasis. In terms of mesorectal nodes, or nodes around those iliac vessels that we mentioned. That is a little bit better done with EUS in terms of evaluating for lymphadenopathy. Sometimes they've actually mentioned that EUS maybe overcalls and upstages nodal metastasis a little bit compared to MRI, because we're able to see such small nodes as small as 3 millimeters on an endoscopic ultrasound, and not all of that will be metastatic disease. So it tends to, if you do TNM classification with EUS, you tend to upstage your patients in terms of rectal cancers as opposed to an MRI. But certainly in terms of the utility of planning surgical intervention for lesions that invade far into the muscle layer, the MRI is better, because you need to know how much of a margin that you have into the mesorectum. So you're able to decide if you need, what kind of surgery you need, number one, and number two, do you need adjuvant chemo radiation?
So may I ask something? Obviously, you've outlined what's feasible, and again, you've shown relatively low numbers of the actual pelvic drainage. Yeah. So it really follows the phase of most innovative things, is that people start doing it, and then they find out really if it works in a comparative manner. But there's a couple of things that maybe sort of older people like myself will remember. But I was responsible for obviously there's transrectal ultrasound for the prostate, and that's in the hands of the prostate surgeons. And transrectal ultrasound for incontinence is in the hands of the coloproctologists. So how do you work with your coloproctologists with this, and what are they doing? Do they know the wonders of these instruments, and are they actually using them? And I am interested, I mean, obviously one wants to, in our environment, use the fewest investigations, either investigative or diagnostic, to get the solution. And that has to be something in our context that has to be evaluated. Are these maneuvers cost effective? And obviously, if you have to have reinterventions, they can get extremely costly to salvage. So perhaps you can let us know about direct probes, which are used for prostate and for assessment of the lower sphincter. Are they still in vogue? And how are you getting on with your coloproctologists?
Okay, let me start by addressing the coloproctologists first. Yes, in terms of evaluating, perianal lesions and pelvic collections, the proctologists, in terms of like fistulae, for example, they really should be the ones that are evaluating these lesions in terms of deciding for surgical intervention. In my center, rectal EUS is performed only by the medical gastroenterologists and not by the proctologists. But I'm finding that we are working a little bit better together in terms of in a multidisciplinary team, deciding which patients are actually appropriate for pelvic, pelvic EUS and rectal EUS and pelvic collection drainage. We're finding that they're obviously getting to the point where maybe these patients are not not necessarily as a primary modality. They're evaluating for patients for percutaneous drainage first, and where it's not feasible coming to EUS, where maybe, in the future we can actually evaluate these drainage modalities as the primary treatment option, as opposed to where percutaneous may have failed. So no, our proctologists do not perform EUS, rectal EUS in our center, but it definitely is a team sport in trying to manage these patients. And maybe this is where, you know, yourself, as you said, with your maturity and experience, have a little bit better, you know, hold on diagnostic rectal EUS. I think evaluating sphincter and sphincter function, as I've mentioned, it's more of it's better sensitivity in picking up anal, rectal, or sphincter abnormalities using radial EUS. I've been trained on linear EUS. We do water submersion and use the water balloon, but we don't use radial EUS as much. We just take a little bit longer trying to make sure that you've done a full circumferential evaluation. But again, it goes with experience. I happen to be mentored by somebody who's quite experienced in EUS, and she's very patient in teaching us. And so you get better at knowing what you're looking at and being able to evaluate. It starts off with knowing the anatomy and then being able to evaluate anything that is abnormal. I'm not sure if there was something else that I missed, Sandy.
No, I think that's a good thing. Better liaison with coloproctologists is a great idea, I think, in terms of multidisciplinary management of these difficult problems, because they're usually difficult problems. They're not simple. But maybe I don't know if we're going to end up, but I think we are over time. But one of the things is when you use EUS to evaluate these lesions that might be potentially curable endoscopically, and when is there much value in doing that if your endoscopic skills are good? Because again, some of these technical resections, local resections, are in the hands of the surgeons, and obviously some are in the hands of the interventional gastroenterologist. Maybe Vikash could ask, when does he actually do an ultrasound on a rectal lesion?
Yeah, so I'm going to say, and it's similar for the upper GI, for the stomach, for the esophagus. I don't think EUS is sensitive enough in telling us the difference between these T1A and T1B lesions. And I still think there doing a good, high-quality endoscopic assessment is probably more valuable there. And by the time you're dealing with deeper invasion, I think that's also endoscopically apparent. So I don't think we're there yet, but once the linear or the high-frequency probes develop more and we start getting more layers, perhaps, but certainly not yet there in terms of assessing early rectal lesions and whether they're amenable to, surgery or endoscopic removal. I think high-quality endoscopy is still the go-to for that there. I don't think there are many local, I do tend to be corrected, proctologists using transrectal or ultrasound. I know Prof. Utley was probably the most well-versed and probably he was the master in it for sure. But as far as I know, I don't think there are many using it locally, at least. I'm not sure about down in Cape Town, but in Joburg, certainly.
Yeah. I think I was only involved peripherally, but for the rectal lesions with incontinence to check the sphincter, I certainly know Claire Warden had that, and we had to get specialized software, and the probe, it's a dedicated probe, which is very high frequency. Again, coming back to this whole thing of how you define the layers in very small areas, and also how you get good contact over what's essentially a lesion that's quite difficult to identify visually when you're using the ultrasound. Anyway, I think that's a fantastic sort of trip through ultrasound, and I learned a lot, that's for sure. And I'd just like to thank everyone, particularly the platform that they use, the New Mexico platform, and India for sorting out the technical glitch very quickly so that we could have this meeting. And I really would like to thank Vikash and also Galia Chinnery for taking on the role of organizing these endoscopy ones. They are really the individuals who are at the cutting edge of trying to take endoscopy back into its rightful place in gastroenterology as a real front-end technique. So well done to you both, and we look forward to those in the new year. Also to remember that this platform is sort of being hosted and run by the Gastro Foundation. Nothing comes for free in this world, and I think it's a phenomenal endeavor to keep this going. I think it's been going now almost 4 years. I might be slightly wrong there, and I think it's definitely a platform that will continue into the into the next decade or so, and I'm looking forward to what comes next year. It remains for me to thank the presenter, and also to thank all the sponsors who have helped the foundation put this together, and to wish you all a great festive season, whatever you're up to. Please don't drink too much and drive safely, but enjoy the new year. And we reconvene on the 24th of January, I think, with pediatric gastroenterology. So we look forward to seeing you all then. And yeah, have a good Christmas and New Year. Take care.
Thanks,
Thanks, Andy.
everybody.
Thanks for all your efforts. Thank you.
Cheers.
Cheers. Cheers.